Hola a todos y a todas, ¿cómo están? Tengan muy pero muy buenas tardes. Sean bienvenidos y bienvenidas a un espacio webinar, iba a decir, pero en rigor, para ser más precisos, a una charla con expertos, que en este caso la Sociedad Argentina de Infectología presenta en el marco, claro, de un simposio de inmunocomprometidos. Pero eso lo podría explicar yo, pero quien mejor lo va a explicar es la doctora Carolina Eppelbaum, de justamente la Comisión de Inmunocomprometidos de la Sociedad Argentina de Infectología. Hola Carolina, te voy a abrir el micrófono. Mientras tanto, antes de escucharte, le voy a decir a los que están del otro lado. Primero que, como ocurre con cada espacio que transmitimos desde aquí, esto queda grabado. Entonces ustedes lo pueden volver a ver, lo pueden recomendar, eso lo pueden compartir con acceso libre en todas nuestras redes sociales. Y después, aclararles que esta charla, por el tenor de nuestro invitado, la va a mantener el doctor Javier Feltra de SADI en inglés. Pero por suerte, vía la generosidad de la doctora Claudia Sergueira, que creo que está por ahí, hicimos una traducción subtitulada, con lo cual para ustedes va a ser simplemente como ver una serie en Netflix, pero muchísimo mejor, porque vamos a poder compartir, y de eso lo va a hablar Carolina, contenidos de mucha actualidad con un invitado del exterior muy, pero muy prestigioso, que también va a estar en este simposio de inmunocomprometidos. Pero Carolina, tengo ganas de decir más, pero si no te quito letra O. Buenas tardes, buen
Muchas
webinar.
gracias. Bueno, buenas tardes a todos. Mi nombre, como me presentó ya el doctor, es Carolina Eppelbaum. Soy médica infectóloga pediatra del Hospital Garrahan y soy miembro de la Comisión de Infecciones en el Huésped Inmunocomprometido de SADI. Esta tarde vamos a contar con la charla del reconocido internacionalmente doctor Thomas Lesbecher, quien es un médico alemán con amplia trayectoria y experiencia en el área de las infecciones en pacientes hemato-oncológicos pediátricos. Hoy nos va a dar una disertación acerca de infecciones fúngicas invasivas en pediatría. Esta charla va a estar coordinada por el doctor Javier Feltra. Las infecciones fúngicas invasivas, como sabemos los que vemos este tipo de pacientes a diario, son un verdadero reto por las dificultades en el diagnóstico, en el tratamiento y en la prevención de este tipo de infecciones, lo que conlleva a los pacientes a una alta morbimortalidad. Todo esto lo va a discutir ahora el doctor Thomas Lesbecher. Y antes de dejarlos comenzar con la charla, quiero recordarles que los días 26 y 27 de septiembre se va a llevar a cabo el cuarto simposio bienal de infecciones en el huésped inmunocomprometido de forma presencial y remota para los que quieran participar a distancia, donde también podrán participar con el Meet the Expert con el doctor Thomas Lesbecher. Bueno, los dejo que disfruten la charla. Muchas gracias y buenas tardes.
Gracias, Carolina. Entonces, como prometimos, vamos a comenzar con esta charla que está dividida en tres partes, así que vamos con la primera.
Presentación. Y en este podcast vamos a charlar sobre infecciones fúngicas invasoras en pediatría con Tomás Lechenbecher, que es doctor en medicina y profesor de pediatría especializado en hematología y oncología pediátrica en la Universidad Johann Wolfgang Goethe en Frankfurt, Alemania. Thomas, it's very nice to be with you here in this podcast. And well, let's start to talk about some topics in investing fungal infections in pediatric populations. Okay. Let's start with the risks of invasive fungal infections in pediatric populations. What do you think about this and the difference? Some kind of difference in others. Do you think there are big difference, big changes?
I mean, that's a good question. It's I think the overall risk factors are very similar between children and adults. So, I mean, the most important risk factor for most of those fungal infections, as you know, is the prolonged and severe neutropenia, which is defined by like prolonged is 10 days and longer, and severe neutropenia is 500 neutrophils per microliter and less. So that's the overriding risk factors. I mean, we know that also because and this is one or might be one of these big differences, we also have children with primary immunodeficiencies, these inborn errors of immunity. So then these patients are not seen that often by the adult doctors. So, for example, the chronic granulomatous disease, where you have the neutrophil defect, is also a very a risk factor. So, but again, it's the neutrophils which are affected. So, what I would say is the long-lasting lack of neutrophils or low neutrophil counts and or the defects of the functionality of neutrophils, whether it's inborn, like in the CGD patients, or, and this is then comparable to the adults again, you see it, for example, when you give high-dose steroids over a long time. So this is basically the overriding risk factors for invasive fungal disease. We know that there are others as well. It's like mucositis, for example, especially for the Candida infections, or the T cell immunodeficiency after stem cell transplantation. So there are a couple of really risk factors for the occurrence of an invasive fungal disease. So overall, I think the risk factors itself, they're quite similar. What we see in terms of difference, that the for example, one big difference between adults and children is the comorbidities, for example. We have them much more often, like the chronic pulmonary disease, which also is like a risk factor. This we see in the adults and not in the, or usually not in the children. What we see also, that we have different kind of underlying malignancies. We treat usually what we have, it's the acute lymphoblastic leukemia, which is much more seldom in the adult setting. And also what we do, we give higher chemotherapy because the kids tolerate it much better than the adults. Maybe last, it's also the immune reconstitution after chemotherapy. It might be also different in the pediatric setting compared to adults. So just to summarize, the risk factors, I think they're pretty similar, but this what is around those patients with comorbidities, what kind of malignancies, treatment, reconstitution, that might be different.
And there is always tend to detect sometimes special patients, especially in special population, there are some mutations for genetic predispositions for develop some invasive fungal infection, alterations, or genetic mutations for toll-like receptors that induce more incidence or increased risk for invasive, especially invasive aspergillosis. We don't detect this mutation, at least in Argentina, for screening every time. It's very rare to do that. But well, in Europe, they are more consistent to detect or try to detect the mutations in the pediatric population, or they keep what you said before, that the underlying disease always was around the pediatric populations, and the disease, the background disease that the children have, you take into account in order to evaluate the risk.
Yeah, no, I agree with you. But the thing is, I mean, those, let's say, genetic mutations are which really render those patients at an extremely high risk that you might prophylax them or to treat them, like with a stem cell transplantation. And then, I mean, this is really rare, I would say. What we were or many people did, including us, and this is really not that. I think that it's not. There's not that much progress that we can define those, as you said, for example, those toll-like receptor. I wouldn't say mutations, but these polymorphisms, which in a combination might on top of some kind of immunodeficiency. So meaning if you are neutropenic and then you have like the toll-like receptor polymorphisms and this polymorphisms, maybe a cytokine polymorphism, that together we try to do this to stratify those patients. And I think there we were not that successful that we really can, according to those polymorphisms, we can stratify those patients in low and middle or intermediate and high risk. That's unfortunately, we were not successful in doing that.
No, you know that there are always, we talk about the epidemiology of invasive fungal infections that are very, very different. There is geographic distribution difference between epidemiology of invasive fungal infections. How you combine these two things, risk and local epidemiology. For example, in our cases, I treat all ovals in my hospital, and you know, the first is the Aspergillus. 10 years ago, the second was Fusarium, and far away was Mucor. Yeah. And now it's changed a little bit, Aspergillus. Second is Mucor, talking about filamentous fungi, of course. We don't see a lot of yeast infections because we make prophylaxis with fluconazole or with Boreo Posacor, depending of the risk. Then it's changed to first Aspergillus and second Mucor and Fusarium and other black fungi, filamental fungi were far away. Then how is your experience about the local epidemiology in your hospital about how important is this to know when you manage this combination between risk and what you know what happened with the epidemiology in your hospital?
I mean, you should know your epidemiology, that's clear. But on the other hand, one has to say, even us, like a big center, I mean, we do not see that many invasive fungal diseases because now with the prophylaxis, that's true. But I mean, it's hard to say whether it changed, whether we have a little bit more Aspergillus or with a little bit more Mucor and so on. It's really hard to say over like 5 years because the numbers overall are so low, and then you might have good or bad luck, and then you have sometimes we see 5 in a short time, sometimes none of them. And you're absolutely right. I mean, I know it from like Brazil, they have a lot of Fusarium. We don't see it basically. And what we did, study in the ALL patient. The ALL patients, the lymphoblastic leukemia, these are our major population of patients we treat. 1/3 of the cancer kids have leukemia or acute lymphoblastic leukemia. And what we did is to look, I mean, now in the last or the before last study, which enrolled about more than 6,000 patients for LL, so homogeneously treated, and we looked to different countries. They do have some, I would say, not really major difference. These were all, except some were treated in Israel, some were treated in Australia, but most of them really in our, like Italy and Austria and Germany. So these really doesn't differ that much. That's one thing, one message. The other thing is, I know that other countries do have really different epidemiologies, and this is what we're doing right now. And this might be like, we try to get as many centers on board. We do with Chile and Brazil, and I think there are some centers, also pediatric centers in Argentina. We collect those data with proven probable fungal infection of those kids who were treated between 2015 and 20. So, or 2010 and 20. So they were treated then we have a long follow-up. And
Yes.
now we just collect those data. We have more than, I think, almost 400 proven probable infections. And this we want to compare between especially Latin America and Europe. So also we have, like in the Nordic countries, whether they differ from Italy. That's a project we are doing right now, because this is really nice when that we have solid data. And coming back to your questions, whether this influences our standard, I mean, I know that we have, I mean, that's what we know. We have mostly Aspergillus, then Candida, and less Mucor. But on the other hand, if you have a kid, I don't know if they have lung infiltrates. So we really do cover also the Mucor as much as possible. So this comes with a question like voriconazole or another broad spectrum and antifungal. So, and I always, except that I really know it's an Aspergillus and this is susceptible, and so I would really go for the broad spectrum antifungals, which also cover Mucor, because we never are sure it's not a Mucor. Even the likelihood is low, but therefore it's a little bit an individualized approach, and the epidemiology helps, but does not decide really what the patient gets.
Yes, that happened to us that the majority of the centers applied to use primary prophylaxis that cover almost Aspergillus and Mucor and almost Fusarium. Most of our cases of epidemiology, let's say, that we recover something, are breakthrough fungal infections.
Yeah.
Most of them. Then this is some kind of bias, let's say. That it's not
Exactly,
real.
exactly.
Because we pressure with drugs, and then we just look what it's not under the sea, like the ice is above. Then it's not real one. It's just two epidemiologists that combine risk and drugs, and then the epidemiology change or may not because the influence of the primary prophylaxis.
Yeah.
Muy bien, esta es la primera parte de 3 en la charla que estamos teniendo, casi como una clase especial, ¿no? Es realmente un lujo que nos damos aquí en la SADI. Vamos entonces con la segunda parte.
We can see what we can see now is that try to tell us or try to imagine how much important is the diagnostic tool in order to make a correct approach. Then diagnosis of fungal infection are very, very, very important in order to diagnose this kind of scenario, like breakthrough.
Right.
What tools are you using in pediatric fungal infection for diagnosis?
I mean,
in general, let's say CT scan or a micro. No?
Yeah, exactly. I mean, you're very limited as everybody in a way, because what we usually do not find is like the fungus in the blood, which would be the nicest thing.
No.
So what we do, and then you have to, distinguish between whether you do like a screening, whether if you do not prophylax, then you do like the galactomannan screening. So we use a lot, and it's more because we prophylax. We use those non-culture based diagnostic tools, and there we usually use the galactomannan, and we do not, and this might be also a difference to the adults, because the beta-glucan in our hand, it's not really, I mean, we did one study and it was basically always positive. So the high false positivity is really a major problem with this beta-glucan. And so this galactomannan we use in the blood, and now what we try, and I'm not sure whether this is really, it's our thought. I mean, we would like to do a little bit more the BAL to find the or to do some tests from the BAL, which is probably the best, because most or many of those, especially the filamentous fungi, they have this they affect the lung. And because it's really difficult to do, I mean, it's different to the adults. They just do it like standardized, like you prolong fever neutropenia, then they do it every week. And we do it, if at all, we do it once, usually, because it's just, then you need anesthesia and so we try to do the deep sputum, or this induced sputum. I'm not sure. This is what we are just looking a little bit, whether they can give us a hint. We do the galactomannan as it is, like with the in the cystic fibrosis. There are some reports that this reflects quite well the BAL, the induced sputum. I don't know whether it's the fact in our patients. And the galactomannan, you might, and this is one thing, the false positivity, if you eat something, you have it probably in the mouth. But we do also then the PCR. I think this is more and more, if you worked with Paul, so and so you're very aware of what's, I mean, probably much better than I am, what's going on. So there is a really a good development. I think quite not a standardization, but the comparability across those results is much better. Whether you use this one or that one, it probably doesn't matter. So I think this is really it's a nice progress that what we can see in this molecular diagnostics. Now I heard also that like the NGS probably will catch up quite a bit. I don't know the most recent results. And also this false positivity that you can, this interpretation of the results. But I think these are really valuable tools you have. And then you decide, I mean, the second part is this, you mentioned this imaging. Usually we do the CT scan, and the MRI is, I think, also is progressing rapidly, because you have also with the lung, which is usually the specialty of the CT scan, but also they have MRIs, which I cannot distinguish whether it's an MRI or a CT scan. So I think this is much better. You don't have the radiation, which we are also as pediatricians afraid of. And then that's what we regularly do, this imaging. And then at the end, you have to decide whether you do a biopsy via the BAL or transcutaneously. This is, I mean, we should do it more often, but we do not. And I think this is exactly what we were saying before. I mean, we have to balance the pros and cons, like the risk that you harm somebody and whether you get some result. And at the end, I mean, that's what I'm think I would like to emphasize this. If we do the lung and we have something in the lung, we should really not forget about the head, because what we saw that, and we had recently a patient had infiltrated in the lung, and this was a probable aspergillosis at the end. The neurologically totally, there was nothing, no problem at all. And then we said, look, the guidelines say, and this is we published sometime a paper on that, like 1/3 of the kids do not have any neurological problems, and this kid neither. And there were like 2 or 3 infiltrates in the head, which you have to know, because you might change your therapy according to this. So that's, I just wanted to emphasize this. With it, you should not look only to the lung.
This is very, very interesting. Absolutely interesting to detect something. It reminds me when we recover yeast from blood and say, well, try to look what happened in the eyes, what happened in the urine, what happened. Just check.
Exactly.
Check the, well, in pediatric population, this message is very, very, very interesting.
Claro que sí, no solamente esto es interesante, sino sobre todo la tercera parte de la charla y última que compartimos en este momento.
Approach for diagnosis tools, how we can move to a treatment, then how you treat these patients in this scenario.
Yeah,
I think you try to do it just to say, well, now it's, well, you have to distinguish the patient A, the difference between patient B, and you try to do the best for each one. And sometimes, right. I don't know if you are fighting with the guidelines.
Yeah, no, I mean,
the time we have to go a little bit outside the guidelines in order to make
our favorite drug is still, it's the liposomal amphotericin B.
Yeah.
For a couple of reasons. One is that it really has a broad activity against most of the fungi. That's one thing. Second, we can give it IV because many of those kids won't swallow, especially if they have mucositis and so on. And the third, and that's I mean, thinking what else do you have? You have the candins. If I have, you know, like a suspicion of Candida infection, sure, then I would go for, like if I had these liver infiltrates and all these things, then I would go for the candins. But if I have a lung infiltrate, I think it's probably or most likely better to have to start with a polyene. And then thinking about it, triazole, like this broad spectrum, the problem is that they have these many, there are two things. They have, one is these drug interactions, which is a major problem because we have a lot of therapeutic protocols which use the vincristine. So we can, this is like a contra indication for an azole with vincristine, many of those things. Second is that if you really have to start treating, that the blood levels, you should really the therapeutic drug monitoring, which is very much recommended, and I think it's good because if you use voriconazole, maybe you never reach a sufficient drug level, and then to wait for 3 days to measure a drug level or a day second, so you just lose the time for an efficient treatment. And therefore we go and start usually with the ambisome or a liposomal amphotericin B because it's the nephrotoxicity, it's just lower and it's better tolerated. Therefore we go, I know that some other countries do not have it in hand, but this is like our first line therapy. And then because as I said, mostly we have a filamentous fungus, and then we think about, we do the diagnostics if they have not been done, and then we might switch at one point also to an azole. But this really depends on the status where whether the kid needs still chemotherapy and also how the kid is doing.
I absolutely agree with you. We need the drugs with less drug-drug interaction because now the chemotherapy, it's a big amount of drugs that produce some side effects and not, but combination of drugs give that this risk for invasive for side effects that we don't want. That mimics many different things that break our head sometimes. And we need drug with less drug interactions. And it's absolutely real that many times, at least in Argentina, we deliver the measure of their drugs level into another institution. Then send the sample go and back, and you lose the first most important things that is treated in the first hours with the best drugs, let's say.
Exactly.
Then this is very important for change the mortality rates, and everybody knows that is later it will be worse, even if the drug is fantastic.
Yeah, I agree.
I think this is a very clear indication when we have to choose what drugs you need to use at the beginning of the treatment. Sometimes at the beginning will be empirical, and then we move to more driven if you need it to do it.
Exactly.
Well, thank you very much that we have this discussion, and we'll see you soon.
So, muchísimas gracias a vos.
Gracias a vos, Tomás. Un gran abrazo. Espero que hayan disfrutado de este podcast y los invitamos a participar del cuarto simposio bienal de infecciones en pacientes inmunocomprometidos que se va a desarrollar aquí en la ciudad de Buenos Aires el 26 y 27 de septiembre. Los esperamos.
Bueno, hemos concluido. Qué valioso momento acabamos de compartir. Allí lo explicaba el doctor Afeltra para el simposio. Bueno, quedó grabado allí, pero si no, ustedes van a buscarlo a la web y ahí encuentran todos los detalles, toda la inscripción, el programa. Se está haciendo un trabajo muy, muy minucioso para que este evento, el número 4, que realice la Sociedad Argentina de Infectología, se desarrolle como los otros 3, con mucho éxito y con gran aporte a lo que es el conocimiento y el derecho a la salud, por supuesto. Gracias por la compañía, nos volvemos a encontrar de un momento a otro. Buenas tardes.